Vijay.
Thank you, Dr. Holmes, and I totally agree. We need more data, more trials, much more evidence before we have an effective program.
It could be a problem that neither of us know how to work the pointer.
This is a slide.
How about here?
Okay.
What do you think?
Okay. Well, that's
Is that it?
Okay. That's okay. Okay. And I want to thank DJ for inviting me. It's been an excellent program. We thoroughly enjoyed it. So what we're going to do is we go over the what do we do creating or setting up a program. Now, most of our work was part of a research program, so that's where we are now. And as more data comes in, you want to convert that into an effective program where we can provide quality care. So we're going to talk about the Arizona experience, what we think should be components of a program, how to measure quality and outcomes, and collect more data. And then once we have a sort of a product, then you want to talk to your referring doctors, get more patients, and maybe have a direct-to-patient effort. So we've been in this space for some time. I think we did our first Watchman case in 2007, and we have a good experience. We did pretty good in the first trial. There was a good patient following and patient experience, and then we started with a LAA program last year. So in terms of enrollments, we enrolled in all the trials, and we have 150 patients enrolled in the Watchman trials, and this is the implants. We have more than 130 implants for Watchman device. So is a left atrial appendage occlusion an attractive opportunity for you guys? Is it better care for patients? All these are questions. And is it better for your practice and hospital economics? It seems like the hospitals are interested in it at this point. So when you talk of a program, it sort of ties into an AFib program. So there is, you have research, you have your cath lab, nursing and staff, echo and anesthesia, very important components of the program. And then you want to engage the hospital and then go marketing. And then you are at the center of this, so you have to drive the whole program. There is no shortcut here. And you have a busy practice, so there are only so many hours in a day, so you have to think about whether you need a program. But if you do, and we did, you have to get your goals right. So the goals are to provide innovative state-of-art therapies early in the game, and you want outstanding patient care. And you achieve this through collaboration, management, optimization of workflow, and you become a recognized leader that fosters an ethical, responsive, and highly effective care. And you continue these improvements, which are sort of essential to the program, and you want to meet or exceed expectations. So when you have that, how do you set it up? So appendage is a multi-specialty field, so there's sort of collaboration of surgeons, anesthesia, echocardiographers, electrophysiologists, as well as interventional cardiologists. So you bring together a multi-specialty team. We adopted and implemented AFib protocols, both for inpatient and outpatient care. We did device structure and process of arrhythmia and AFib clinics, so to include appendage as a component. And then you want to then, once you have this going, you want to define quality outcomes and have a tracking system. And once you have a good track record, then you want to devise marketing and awareness strategies. So I think these are the steps you would need to do to develop an effective program. So the first thing is that it's a tough one. Who's going to do these implants? You know, it'll be interventional cardiologists, electrophysiologists, surgeons in the practice. And that's the first question people ask me. Well, there is no right answer. So I think you should start with a collaborative approach. So you could do it together, or you could say fair trade. Septum is yours, appendage is mine, or something like that. But it's a little tough. What it'll end up being is that you probably start as a combined procedure, and then one person has more time, has more interest, and puts in more effort. He'll probably take it. Because I think it's not a very efficient program when you have too many people involved. You do want to concentrate the experience, especially early in the game. But electrophysiologists have certain advantages in this thing. They have an AFib practice, maybe an AFib program. They offer other AFib services. They've done more transeptals and pericardial procedures. And they're generally familiar with the left atrial anatomy. But the interventional cardiologists do really good too, because they have good interventional skills, and it's like deploying the stent and deploying the appendage occlusion device, not much different. They have better links to primary care. Primary care people refer to them, whereas 80% of electrophysiologists' business comes from cardiologists. And they, I think, have better echo skills. They do more echoes than we do. So the research is an integral part of the program right now. So if you don't have a research program, at least at this time, an occlusion program is difficult to come by. And then research programs are effective now. We are sort of a private practice, academically oriented. We do more research trials than most other centers. So they're not profit centers, though. They don't bring money, but they do help us in many ways, which is sort of not measurable. It gives us access to newer technology. It helps us analyze the quality and direction of what we're doing, and you look back and become a better doctor. It does increase physician and patient loyalty because they know you can do this where others can't. And there are other marketing benefits. So you can effectively market your skills to physicians, hospitals, payers, and patients. So this works pretty good. The echocardiography, again, a very important piece in this thing. You need commitment from your echo colleagues. And that's difficult because they don't want to spend 3 hours with you when they have a busy clinic. And in a private practice, this is almost impossible. And then your own echo skills are very critical to success of the implant. So if you don't see the images yourself, this is not going to work. But I think this is a call. Electrophysiologists and interventional electrophysiologists need to be better echocardiographers. There is no doubt about it. Anesthesia. Again, if you have a consistent anesthesia team, the procedure becomes much more pleasant to work with. I mean, anesthesia people can help you with the TEE when your echo colleague is not there. It is a method of choice. I mean, there is no other way you can do it. You need intraoperative TEE. There has to be general anesthesia. And then you can create apnea when you are in the critical parts of the procedure, basically pericardial puncture and device deployment. So that gives you a big advantage. And then they are recovered and they back here, they go home the next day. It's generally a very good patient experience. Now you've figured everything out. Now you have to engage the hospital to support you. So this is the other critical piece for interventional cardiologists and electrophysiologists. We're not taught how to do this, but they expect you to be a physician executive. You need to know. So you need the hospital. There will be privileging issues. You need procedure scheduling, staffing of the lab. You want to go from one lab to the other and come back. There's training and education of the staff and the hospital employees. And then there's the marketing piece. They have marketing dollars to spend. And it will facilitate the development of a program if you can engage them. So you have to talk their language. How do you engage them? I mean, you need to know what the DRGs are. what the hospital reimbursement is, what is the contribution margin, what is charge to cost ratio, is the service line profitable, what is the opportunity and growth, and how do you increase efficiency and safety? All these things are very important to the hospital. They like these heat maps. If you, I don't know, this is a heat map of AFib. So they get this data of how many discharges with a diagnosis of AFib in every region. So you can, this is California, but you can do any region, and you know how much AFib population is around you. We make geographical maps, you know where the centers are and where is this pocket of opportunity. And then they want numbers. See, you want to go and tell them, okay, there are 60,000 or whatever. This is just numbers. But diagnosed AFib patients, 20,000, thousands, 20,000 undiagnosed. You have 30,000 ablation candidates and 5,000 appendage occlusion candidates. They want to see these numbers. They want to see these graphs that, okay, well, the AFib, there'll be 5.6 million AFib cases by 2050. And the EP procedures will keep increasing. And then the contribution margin. So that is the net profit they make from each procedure. It looks like the best contribution margin is for the surgeon. So all surgical programs are sort of well supported by the hospital. EP does pretty good. It's now higher than vascular and interventional colleagues. And then service line profitability. See how it has changed. 97, general surgery was pretty good, but now cardiac procedures, their profitability is 40%. So these things keep changing. Once you analyze your program, then you say what are the strengths, weaknesses, opportunities, and you make interventions. So does it mean you have to go and talk a lot, or talk to all the practices, give talks, and recruit more patients, talk to your primary care doctor, give them the tools, and you have a patient awareness campaign. And then we don't have the cost effectiveness data. We got it. In this environment, we need to be cost effective. And this data needs to be more robust and available. I mean, once you do appendage occlusion, there will be not many visits for Coumadin and Coumadin-related complications. The nursing and staff education is important. The lab staff, when they're into this procedure, they're interested in it and they want to do all this thing, they contribute to the efficiency and the success of your procedure. And when you have a knowledgeable staff and nurses, the patient experience is far better. They educate them, they tell them exactly what they're going to go into and what they're into. We work really hard on this piece. So DJ invited me here. I was coming Thursday. We did 4 cases before 11:30 so I could take my flight, and they helped me do it. The marketing is an interesting piece. Once you have a program, you have to use your outcome data to say that it's safe and effective. Patient testimonials help. Nobody likes anything better than patient stories. You can engage the physicians and other practices. Public talks are effective for AFib. These AFib symposiums for patients. Newspaper, conventional media. There's this new social media, which we do need to get into because that's going to be where the future of marketing is. And then there is this targeted marketing. The hospitals have these data on who has arrhythmia, and they can send direct mailers to people who have a diagnosis of arrhythmia and stuff. And then you can go to your physicians to get these referrals. There is your own group and hospital. That's an easy target. It's low-hanging fruit. I mean, this thing, you can always convince them, show them how much you can improve quality of life, and that really works very well. And then we've had great success targeting community cardiologists, but that was partly because nobody else was doing it. but it may be a different story. Primary care physicians, important resource. A lot of people, sometimes, if the primary care doctor wants somebody off Coumadin, they will send them to you. They will bypass everybody else upstreams. The specialists, the renal guys, see a lot of people with comorbidities. They have atrial fibrillation, high incidence, and they don't like Coumadin during dialysis. So they may be an important target for you. The gastroenterologists see a lot of GI bleeds. They see them all the time. And if they have a referral area where they could refer to you for an opinion, that'll work pretty good. The neurologists, they see stroke all the time. And they generally don't like Coumadin. They want their patients to be on aspirin and Plavix, which makes sense. So they don't like triple therapy, and they'll be another great target. Your own interventional doctors who are who have patients on triple therapy because of Coumadin, there's another great target for appendage occlusion devices. So I think, at least for us, you have to link this to an AFib program. For an appendage occlusion program to be successful as a quality program, it's probably better linked to a comprehensive AFib program where you can offer other therapies. So in conclusion, left atrial appendage occlusion is another tool for prevention of stroke, just another tool in patients with atrial fibrillation. And it has a great potential, and we're not there yet, a great potential to be an important component of your practice. So, Arizona, Phoenix is way better this time of the year. Great, thank you.
That was fantastic. We're going to save questions and have a panel discussion at the end. We're going to move ahead and talk about then transesophageal echo in left atrial appendage exclusion.